Well, hey, I'm Mike Gibson. Welcome to this morning's webinar where we're going to be talking about secondary prevention with aspirin. And we're also going to be talking about one of the most recent advances in the field, a new aspirin formulation. So thanks for joining today. These are my disclosures. I do have consulting funding from PLX. One of the folks we'll be talking about today who has a new aspirin formulation. I also have research grant support and consulting funding from all major manufacturers of antiplatelets and antithrombins. Well, what do we hope to get out of today's webinar? At the end of this, I hope you'll understand where we're at in the guidelines about primary prevention and secondary prevention with aspirin. Make it really clear that for secondary prevention, aspirin remains a 1A recommendation. There's been a lot of confusion out there. The other thing we'll talk about is this new formulation of phospholipid aspirin and some of its advantages. And the third thing we'll talk about is patients come in different sizes and risks and how we have to tailor the therapy to match and optimize the risk-benefit ratio. So a lot of confusion out there right now about aspirin. There was recently an announcement from the USPTF saying that, for primary prevention, if you've never had an event before, the benefits may not outweigh the risks of aspirin. And that created a lot of confusion. I know I had patients calling, relatives calling, saying, should I stop my aspirin? And I've been encouraging patients to contact their doctor, by the way, because it is so confusing. A lot of people don't realize that the recommendation was for that primary prevention, preventing the first event. It does not apply to those people who've had a heart attack, an acute coronary syndrome, or a stroke. There, the benefits of aspirin continue to outweigh the risk. And there, in secondary prevention, it remains a 1A recommendation for indefinite treatment. What's the data to support aspirin therapy? Well, long ago, there was a trial called the ISIS-2 study in heart attack patients where aspirin was just as good as streptokinase, one of the clot busters, in reducing mortality. Of course, when you put the two together, the results were even better. So aspirin truly can be life-saving in that kind of setting. When you look at the 195 randomized trials that have been done, you do see a benefit in death, MI, and stroke for aspirin. The rates are shown here, 13.2% without aspirin, and that's reduced down to 10.7% with aspirin. So a very robust event reduction with aspirin after you've had an acute coronary syndrome. So that forms the basis for the label for aspirin, saying that it's labeled to reduce those events. It also forms the basis for this guideline recommendation. These are the most recent guidelines. I've highlighted in red for you here. The current guidelines say aspirin maintenance doses are recommended indefinitely. So that's the current 1A, the highest level of recommendation that you can have. Now, in the acute setting, when someone's presenting with an acute coronary syndrome, they recommend that you get non-enteric coated aspirin or immediate release aspirin. And we'll look at some of the data that shows why, because there is delayed absorption and delayed platelet inhibition with that enteric coating. The other thing that has gained a lot of momentum is the use of 81 milligrams as a maintenance dose. That's given a 2A recommendation here. And as I said before, the indefinite use remains a 1A recommendation. Now, there is a lot of debate and a lot of confusion out there about the optimal duration of dual antiplatelet therapy after PCI. Notice that this says after PCI here. A lot of the studies studied just that, after PCI. They were not in ACS patients. So you have to understand that. The other thing you have to understand about these studies, and I led one of them, the Twilight study, is we didn't drop aspirin until 3 months, not 1 month, but 3 months after the PCI. And that's certainly the case in some of the other studies. The other thing you need to understand about some of this data is the non-inferiority boundary, the kind of landing zone to say whether, dropping one drug or another was just as effective, was very, very broad in these studies. They were small, slightly smaller studies, much smaller studies, frankly, than a lot of the pivotal trials that we traditionally do, on the order of thousands of patients, not tens of thousands of patients. So I think there's still some skepticism about, have we excluded an ischemic risk with this progressive shortening of dual antiplatelet therapy? But nonetheless, at the end of the day, you have to balance the risk of ischemia with the risk of bleeding. If you have someone where you are worried about the risk of bleeding, certainly the guidelines give you leeway to stop antiplatelets earlier. But if you have someone where they're low risk of bleeding, but yet have a high risk of ischemia, lots of metal, left main location, complex PCI, and a thrombotic lesion, then those are the ones that you probably want to keep on longer duration of DAP. But it's a very individual decision and will vary patient by patient. Well, how does aspirin work? It works by inhibiting what's called cyclooxygenase. And there's two forms here. There's COX-1 and COX-2. COX-1 is involved in making thromboxane synthase. And when you give low dose aspirin, that's what you're blocking. You're blocking that one. And by blocking thromboxane, you're blocking platelet aggregation. That's why low doses seem to work pretty well. When you give high doses, you tend to also block vasodilation, and you block the prostaglandin production that protects your stomach. So that has not been in as much favor in recent studies. Of course, in the Plato study, we learned that the advantage of ticagrelor was lost in people who had high dose aspirin. Well, there are some concerns about aspirin, long-standing ones, mostly surrounding GI toxicity. You do get some dyspepsia in some patients, and you can get GI bleeding in some patients. There's two ways you have GI toxicity. One is a direct toxicity of the aspirin on the local wall of the stomach. And we're going to look at that in detail on the next slide. The other mechanism is a systemic mechanism where aspirin blocks those prostaglandins, and those prostaglandins are protective of the stomach, and that makes the stomach vulnerable. Of course, if you do have an ulcer, erosion, or some bleeding, you have an antiplatelet effect, and that may cause you to have more bleeding than if you weren't on aspirin. I'm going to focus really on two or three key slides. This is one of them. If you want to remember one thing from today, remember this slide. And this was a lesson for me, actually, in the mechanism. How does aspirin damage the stomach locally? Well, obviously, the stomach has the gastric mucosa. That's the lining. But sitting on top of that is a protective layer, a hydrophobic layer of phospholipids. And those phospholipids don't let the acid come in contact with the mucosal cells. Now, this is what I didn't know. Non-steroidals and aspirin, they associate with, I'm not talking about a covalent bond, but I'm talking about an electrostatic association with those phospholipids. And when aspirin associates with the phospholipids, it changes the architecture of that protective layer, and it begins to leak. And what can happen is the the acid can penetrate that layer and go and damage the mucosal cells. So what if instead of letting the aspirin associate with the phospholipids in the stomach, what if we pre-associated it with, or surrounded it with, or embedded it in phospholipids? And that's the basis of the phospholipid aspirin. It comes already surrounded, already associated with phospholipids. And when it gets into the stomach, it's not going to disrupt that protective barrier. In fact, it gets across easily, kind of like a Trojan horse, and makes its way through that protective barrier without damaging it. This is going to be key to minimizing damage to the stomach and reducing ulcers and erosions. We're going to talk about 3 aspirins today. The one that you're most familiar with, regular aspirin, which is immediate release aspirin. We're going to talk about enteric-coated aspirin, and then we're also going to focus on the latest FDA-approved aspirin, which is this phospholipid aspirin that I mentioned. Let's start with enteric-coated aspirin. It was developed about 50 years ago because of concerns about bleeding. The key thing to know is it's kind of coated in wax. That wax kind of keeps it intact in the stomach, and it dissolves and then releases the aspirin further down in the GI tract. Now, there's still debate, and the evidence is not clear as to whether that really reduces gastric injury or does it just move it from one spot to a different spot. There's debate in the literature. It's not entirely clear whether it really reduces GI bleeding. But what is clear and is in the FDA label is that enteric-coated aspirin has, and I put it in quotes here, erratic absorption, end quote. I took that directly from the label. If you have erratic absorption, then you're going to have erratic platelet inhibition, and that leads to concern about consistency and predictability of response. So if you wanted to build a better aspirin, what would you do? And I'm giving you 4 P's here. You would want one that is prompt, kind of like immediate release aspirin currently, that gets your drug level very quickly. You'd want one that is potent, that is, that achieves its pharmacodynamic effect of inhibiting thromboxane and blocking platelets. You'd want that. And the 3rd P is one that's predictable. You would want very few non-responders. In other words, you would want the majority of people to have 99% inhibition of thromboxane. That would be the goal. And you'd want to accomplish all of that with the 4th P, which is protection. You want an aspirin which is not going to disrupt those phospholipids and is not going to give you erosions or ulcers, or at least reduce the risk of erosions and ulcers. If we can make something that reduces ulcers and erosions, we might also, have a drug that people would be more compliant with and adhere to better. There's another P I'm going to talk a bit about later, and that is persistence. You want that inhibition to be persistent when you take the drug so that you don't lose its inhibition when you come to the next dose. Slide number 2 that I want you to remember, and this is a picture of the mechanism of action of Vazalore, the phospholipid aspirin. When you swallow it, that's what it looks like on the left. It's a liquid aspirin. It's very small capsule. And if you broke it apart, and I should break it apart for you in one of these webinars, there is this moist, gooey, kind of mucousy phospholipid stuff inside of it. And of course, that is the phospholipid surrounding all the little teeny tiny aspirin molecules. So of course, the capsule is going to dissolve. In gold here, you see those phospholipids surrounding the aspirin being released. And then like, and this is our hypothesis, like a Trojan horse, it kind of gets across those phospholipids. That's where you see it kind of penetrating the wall. And here is the thing about the drug delivery mechanism. It's pH dependent. So at low pH, the phospholipids are associated with the aspirin and giving protection. But at high pH, the phospholipids, they fall off and it becomes free aspirin. So as it enters the phospholipid area, it is still attached to the phospholipids. But once it gets to your artery in your bloodstream where the pH is higher, the phospholipids break off, dissociate, and then you've got free aspirin. So our hypothesis is that this is, this phospholipid uh, embedding of the aspirin is a bit like a Trojan horse. It allows it to get through the phospholipids that are protective. And then once the pH rises, you release free aspirin. Let's look at some of the risk of erosions and ulcers. This was an endoscopy study. These people, these 204 healthy volunteers, took 325 of immediate release aspirin or the phospholipid aspirin. They got endoscopy 7 days later. The pictures from the endoscopy were sent to a central core lab that was blinded. They don't know who got phospholipid aspirin, and they don't know who got regular aspirin. And when they looked at the images, they found that there was a highly significant reduction in both ulcers and erosions. That's what you see on the left-hand side here, almost a halving of that. And then if you look over on the right-hand side, that's just ulcers alone, significant reduction in ulcers from 17.6% down to 5.1% with the phospholipid coating, a more than threefold reduction, in ulcers. Now, this is a couple hundred patients. This is not a bleeding study. I've heard some gastroenterologists refer to erosions and ulcers as a biomarker of the risk of bleeding. But what we do know clearly here is that at a week, you reduce your risk of ulcers and erosions with the phospholipid aspirin. That is some safety information. Now let's look at some effectiveness information. One of the things you wonder, does this phospholipid aspirin get absorbed as quickly as regular immediate release aspirin? And the answer is yes. These were 32 healthy subjects who got 325 milligrams of aspirin. And you can see both acetylsalicylic acid and salicylic acid, both levels went up the same with the compounds. So bioequivalent in terms of absorption with regular aspirin. Now, let's talk about enteric-coated aspirin. This study was a study of 40 people. They were diabetics, obese, and they got all three drugs. They got regular immediate release aspirin at one time. They came back at another time. They got the phospholipid aspirin. They came back a third time and they got the enteric coated aspirins. They got all of them. And what you see here is the rate of drug absorption. You see the black and the blue bars there for immediate release aspirin and the phospholipid aspirin. I'll point out that the phospholipid aspirin was at the highest level there, and the error bars don't overlap plain aspirin. It's doing a little better early on. And then I'll also point out, though, the gray. The gray is enteric-coated aspirin. You can see that it's delayed in its absorption by a few hours. And secondly, you will see that the height of that gray curve is lower, meaning there's less drug absorbed. So delayed and reduced absorption with enteric-coated aspirin. Now, they looked at these same 40 people. They got all three drugs, and then they looked at, how long did it take you? How long did it take you to achieve that 99% inhibition of thromboxane? And what you see here is that for both plain aspirin and phospholipid aspirin, it was pretty quick and similar. But look at the delay with enteric-coated aspirin. It was 2 to 3 times longer to achieve that complete inhibition. That's the time. What's delayed in terms of timing. The second issue is some people never got there. Some people were non-responders. So not only delayed, but may not have ever happened in some people. So what you see here is the same 40 people getting all three drugs, and plain aspirin is on the left. The blue curves are people who achieved 99% inhibition of thromboxane. That is an accepted way of looking at adequate inhibition. Also, you look over at the phospholipid aspirin in the middle, similar in the number of blues, but look over on the far right. That is enteric-coated aspirin. You see fewer people in blue. That is, fewer people achieved 99% inhibition. And look at all the people in red. Those are the people who did not achieve 99% inhibition, and those numbers are lower. Some people didn't respond at all. So, the point is you get a more predictable response with immediate release and with phospholipid aspirin than you do with enteric-coated aspirin. One of the things we like to know, you can look at drug levels and all that, but at the end of the day, we want to know, was the platelet inhibited? And this looks at the amount of clotting or platelet aggregation. And again, these are the same 40 people, all three drugs. And a high number here means you're getting a lot of clotting. A low number here means you're not clotting. And what you see for both phospholipid aspirin and immediate release aspirin, after you ingest it, look at the clotting. It drops rapidly and immediately. And it goes down to, 10% clotting of where you started. Look over at the gray. It takes longer for it to achieve that, out to say 6 hours for you to achieve that same level of platelet inhibition. So delayed. And this is why in the acute setting, we recommend people take enteric-coated or phospholipid aspirin, which acts immediately. So I wanted to kind of circle back to the non-responder issue. In the middle of this Venn diagram, you see, how many people are not responsive to all three drugs. It's very few people, only 5.7%. But let's look at each drug. The phospholipid aspirin had 8.1% of people who are non-responders. Immediate release aspirin was about double that at 15.8% were non-responders. But look at enteric-coated aspirin, 52.8%. Manyfold higher of them did not achieve full inhibition. That's 99% inhibition of thromboxane. So a lot of variability in responsiveness. Now, one of the things that doctors frequently tell patients, or maybe their relatives tell them, is, if the aspirin's tough on your stomach, take it with food. And I want to show you here what happens when you take aspirin with food. It really delays absorption and can make the absorption more erratic. At the top here, we're looking at 8 healthy people who took aspirin without food. That's the top left. You see it acts pretty quickly, see pretty good consistency. But in the top right, look what happens when they take it with food. You see a delay with immediate release aspirin, and you see much more variability. Now look at the bottom panels. That's enteric-coated aspirin. And there you do see, even without food, in the fasting state, it's delayed. We know that's going to happen because the enteric coating. But look what happens when you take it with food. you do see much delayed absorption and erratic absorption when you take it with food. Now let's compare that and contrast it with the phospholipid aspirin. You see the curves are more highly overlapping here in the fasting state and in the fed state. A little delay, as you saw with immediate release aspirin, but a fairly consistent absorption. A lot of people out there are taking 81 milligrams of enteric-coated aspirin. How does the phospholipid aspirin compare with that? Well, what you see here are two take-home messages. This is the third slide I really want you to focus on. The bottom line is the phospholipid aspirin gets you faster absorption and more complete absorption, higher levels of potency. Let's look at the top graph. This is the levels in the bloodstream of the active drug. And what you see in purple is the phospholipid aspirin. You see it gets absorbed immediately. And what you see with the phospholipid aspirin is high drug levels. Compare that in gray to the enteric-coated aspirin. It gets absorbed more slowly. You see a peak out at 4 hours. And you also see less than half of the drug levels. So its peak is less than half that of the phospholipid aspirin. Let's look at clotting of platelets at the bottom. And what you see here is, again, as you'd predict, the purple line shows immediate, very quick, rather, blockade of the platelet clotting down in a couple hours. But you also, again, see a delay in the platelet clotting with enteric-coated aspirin at 81 milligrams. Not only a delay, but you see less inhibition of platelet clotting with the enteric-coated aspirin. And these p-values you can see here show the differences at these different time points. What I found notable in this is that reduced inhibition persisted. And what I found interesting here is that for enteric-coated aspirin at 24 hours, you were kind of back up to where you started from. So by 24 hours, some of the effect had worn off. Two other issues I wanted to point out. One of them has to do with body weight. This is something I didn't know and I learned recently. High body weight is associated with poor absorption of aspirin. And what you see in these plots is the body weight going left to right. As you see the body weight go up, you see the percent inhibition of thromboxane, the effectiveness goes down. And what these authors did is they figured out, at what weight do you lose that 99% inhibition? And they found for the enteric-coated aspirin, or I'm sorry, for the phospholipid aspirin at the top, you lost that inhibition at about 131 kilograms. But for enteric-coated aspirin, you lost that inhibition at 95 kilograms. So, you had a greater ability to get good absorption in greater obese patients with the phospholipid aspirin. What are some considerations for healthcare providers? We need to do a lot of education. There's been a lot of confusion out there about aspirin in primary and secondary prevention. You have to underscore to your patients, don't stop your aspirin without talking to your healthcare provider. If you have had a heart attack or stroke, you should consider continuing your aspirin under the guidance of your healthcare provider. And I think we have a lot of work to do emphasizing the importance of compliance. We didn't get to hit on it during the presentation, but another common medicine out there are the non-steroidals like ibuprofen. People are not aware of the fact that if you take ibuprofen at the same time as aspirin, it blocks the aspirin absorption. So if you're going to take ibuprofen, you need to take it a few hours after the aspirin so the aspirin can get absorbed. This is something so simple but so important. Take your aspirin with water, not with food. The food is really delaying absorption and reducing absorption. Tailor your dosing, particularly in people at high risk, the obese and diabetic patients. I was really kind of fascinated by what I just learned about the interaction of weight with aspirin absorption. And I would also urge you to think about this newer formulation of aspirin, this phospholipid aspirin, which gives you the immediate release of regular aspirin, but also gives you the protection of reducing ulcers and erosions compared with regular aspirin. Finally, I'll conclude. Remember, aspirin remains the foundational therapy in secondary prevention. Every patient's different. You've got to assess the risk and benefit of aspirin and dosing and formulation in every patient. A lot of debate out there about the optimal duration of DAPT. I think there are a lot of unsettled issues there. I'm underwhelmed by some of the data given the sample sizes and broad non-inferiority margins that were used in those trials. I think we need more data. Remember that aspirin remains a class 1A indication indefinitely. Remember, in ACS patients, time is myocardium. We feel the need for speed, the immediate release, and phospholipid aspirins get you inhibited more quickly. And we not only have to educate people at the beginning, but we have to continue to re-educate our patients about staying on aspirin and being compliant with that.